So this is the continuing story of my son Grayson, who has a condition called Oligoarticular Juvenile Idiopathic Arthritis, or Oligoarticular JIA. In this video, I'm going to be discussing the most serious consequence of his condition, which is the fact that he has uveitis in his eye, in only his left eye. In the previous video, I talked about the knee treatment, and I talked about how readily the knee issues were resolved. The synovial membranes of his knee were inflamed, and through simply an NSAID, a high-dose NSAID, injecting cortisol into his knee, and then withdrawing some of the fluids of his knee, it seemed as though the issue is basically resolved. He's never really had any further consequences other than a little bit of a twinge here and there. He's never had another flare-up in his knee. So now we turn our attention to uveitis, and this is probably about the 5th time that I've started this video because the story is actually really complicated and has many twists and turns. So it's probably going to turn into 2 different videos because I actually really want to get into the science behind the way all of this stuff works as well. And so I'll put all the science into a different video, don't worry. Today I'm just going to be as much as possible simplifying the story and telling the story just sort of as it happened. So January 3rd of 2019, we saw a rheumatologist who was treating this very specific problem of the knees, and that's what they were paying attention to. But they did sort of say offhand, it's possible that your child might also have this condition called uveitis in his eyes. They actually didn't think that it was very likely, and now that I've kind of done research about it, I kind of know why that is. Statistically speaking, generally speaking, most children are diagnosed with JIA much earlier, and uveitis does not actually show itself until several years later. So they were probably thinking in their minds we would have to continue to monitor for uveitis, but that we wouldn't actually see it in this moment. But he did in fact have it. So on February 8th, 2019, we saw an ophthalmologist, a pediatric ophthalmologist for the first time. Remember, he was still 6.5 years old. And right away we noticed, right away with the first eye test that they gave him, we noticed that his left eye had diminished vision. He was not 20. He was 20/20 as in his right eye, but not in his left eye. And he was missing a lot of the letters when he blocked off the right eye. And it turns out his eye was actually diminished by the inflammation that he had in there. So at this visit, the ophthalmologist allowed me to look through, I think it's called the ophthalmoscope. I don't know how to pronounce that, ophthalmoscope. Anyway, I was able to look into his eye. And first of all, she showed me the right eye. And she said, "What do you see?" And I said, "I don't see anything. What am I supposed to be seeing? All I saw was darkness." And then she said, "Yes, that's what you're supposed to see. That's actually a healthy eye." And then she switched me to the left eye. And Grayson's left eye had a blizzard in there. I saw the blackness, and then I saw a blizzard, all these white little flakes in there, which it turns out was actually the inflammation. And the metric that we were given at that time was greater than 100 cells. So what we were actually looking at was white blood cells floating around inside of the aqueous humor of his eye. Since the leg problem was an easy fix, I was kind of just anxious for, okay, let's get it on with it. Let's resolve this eye problem. Let's get done with it. It was not to be that easy. The uveitis is it's just a really difficult problem to resolve. And it turns out that, and hopefully not in his case, but many people who suffer from uveitis continue to suffer from it throughout their lifetime and always have to be diligent and stay on top of the medical protocols, which are not always easy. So yeah, we had all of these visits, January, February, March. We were always driving to this hospital that was an hour away from our home, several times a week, honestly, because we were either dealing with a knee problem or we were starting to deal with these eye problems. And I was just like, okay, when is this going to end? I have a full-time job here. Let's get it over with. And it slowly dawned on me that the eye problem just wasn't going to resolve that easily. It was sort of an awakening into the world of uveitis. This is not a typical illness that you can just, treat it and knock it out and it's done. Nope, you really have to think about how to approach it. And I would say that it's fair to say that every patient truly is individual in how they respond to the different medications and so on. And I'll talk a little bit about that. So the balance of 2019 was trying to resolve exactly which treatment plan was going to work best for Grayson. We start with February 13th, which was 5 days after our first visit. The first ophthalmologist was able to diagnose the fact that he had uveitis, and she was able to put a number on it. However, she is not a uveitis specialist, so she switched us to a different ophthalmologist who is a specialist in uveitis. It turns out that there are not many of them out there. There was only one at Children's Hospital. And so we kind of clung to her. We were introduced to a new number, which was a scale of the amount of inflammatory markers in his eye. It goes 0, of course, is none, and then 1, 2, 3, and then 4+. 4+ basically means so much inflammation that it's hard to quantify. At the first visit, the first ophthalmologist could not count the cells. She put the number on there that was greater than 100. At this visit, we first came across this scale, 0, 1, 2, 3, 4+. And in his case, he was actually at 4+. He had a great deal of inflammation. The problems that he had were he had these keratinic precipitates, KPs, that I think they develop on the posterior side or the back side of the cornea. He had all of those cells, of course, floating around in his aqueous humor, the fluid at the front of the eye. And then superiorly, there are tissues. There's a muscle called the ciliary muscle, which attaches to the lens, allows for the fattening and the thinning of the lens if you're looking at something close up or far away. That's the job of the ciliary muscle or the ciliary body. The ciliary muscle, as far as I can tell, is the tissue that actually becomes inflamed in the case of uveitis, in the case of anterior uveitis, which is what he had. So superiorly, the ciliary body and the iris seem to be kind of fused together, which I believe was simply the fact that there was so much inflammation that these tissues were touching in a way that was not anatomically correct. So the good news is the anterior uveitis is much more readily treatable and not quite as serious as posterior uveitis. There's actually 3 different kinds. There's anterior, intermediate, and posterior. So at the anterior of the eye, you have, the cornea, the lens, and this aqueous humor and these tissues. At the back of the eye, at the posterior of the eye, the chamber of the eye is filled with this vitreous humor. And then behind that, you have the most important structures of your eye for sure, which would be the photoreceptors, the light-sensitive cells that are in your lens, in the retina at the back. You also have a choroid layer, which is the blood vessels, and then pigmented layer back there. And then you have, what else is back there? You have the optic nerve. Posterior uveitis is where the inflammation either already is there or it's possible that the anterior can slip back to the posterior. One of the stresses that we had at this point was to ensure that the inflammation remained in the anterior part of the eye, in the front of the eye, and did not slip to the back of the eye. The ophthalmologist reiterated that JIA and uveitis are usually diagnosed at a younger age and inquired as to a source of stress and suggested that if it was at all possible to remove the source of stress, if there was a source of stress, to remove it, we had a conversation about that. So I may go into that in another video. There was in fact a source of stress, and if Grayson's comfortable talking about that, then I will certainly be happy to talk about that as well. As far as I can tell, there's basically 3 different types of inflammation in your body. There's acute, there's episodic, and then there's chronic. Acute versions of inflammation are actually really helpful. They're the kinds of things that help you heal your wounds. They're the kind of things that when you get a bump on your head, that's an inflammation helping to kind of heal all of the damage in that area, and then it goes away. This is an acute condition. You need inflammation. It helps you to heal. The episodic and chronic versions, however, are the ones that we have to worry about because they can cause long-term damage to the body. So I think, I don't know enough about these things, but I believe the problem in his knees, his JIA symptoms in his knees, are episodic, which means they have episodes, they come and go. But the problem in his eyes is chronic, which means that the inflammation came, it became 4+, and then it remained high. So let's talk about treatment. We started with a localized treatment. This is a typical way that you start to treat uveitis, with topical eye drops, which are steroid eye drops. Remember that with his knee, the thing that really fixed his knee were steroids, and so I had high hopes that these steroid eye drops would do the trick. And they did to a certain extent. They took him from a 4+ down to a 2, and so it did mitigate some of the inflammation. But in reality, what we were aiming for was a 0. We really wanted 0 markers of inflammation at all. And the steroid eye drops weren't really doing it. Additionally, they were causing a certain amount of trouble. So steroids, as you probably know, you can't really take steroids long term. It's never going to be a long-term fix for just about anything, because at the same time as they're fixing one problem, they're oftentimes causing other problems. In the case of inflammation of the eyes, the ciliary muscle, which is the problem, what you want to do is you want the steroid eye drops to target those cells. They're actually smooth muscle cells inside of that ciliary body. The muscle cells, as far as I know, they start to kind of expand and they start to sort of exchange lots of fluids with each other. And part of what the steroid eye drops do, is they start to kind of close down those gap junctions between the cells, so that there isn't quite as much fluid being exchanged back and forth, and it actually makes the cells less active as a result. So steroids always go in, make things less active. They basically target the DNA directly in cells, and I'm saying too many things. But because they're not very precise, it's not a scalpel, it's a hammer. Is that the right expression? It's not a scalpel, it's a hammer. It's broad. It has a broad reach. It also shuts down other cells that you might want them to keep working. For example, there is what's it called? Trabecular network? Yes, a trabecular meshwork that drains the eye. So all this aqueous humor in the front of the eye is produced on a regular basis, actually by the ciliary muscles, and it's continuously produced, therefore it needs to be continuously drained. There's a trabecular meshwork that allows for the drainage of that fluid. And in the case, and you need cells that are active in that area to help with that drainage process. So one of the things that steroid eye drops do is they start to shut down the cells that are helping to drain the aqueous humor. Therefore, the aqueous humor starts to build up. It can cause damage to the lens, to the cornea, cataracts. It can cause glaucoma. This was actually the thing that they were most worried about. And in fact, it did cause a certain amount of pressure buildup inside of that anterior of Grayson's eye. He's what we call an intermediate responder, where his eye was building up pressure, a little bit of pressure every time we came in. You want the eye pressure of the eye to be below 20. His was typically 22 to 25. Because, again, his cells were kind of shutting down all over. They were diminishing their activity, and therefore his eye was not draining properly. He wasn't a high or an extreme responder because his pressure was under 30. I think if it was over 30, we'd have to, stop the eye drops immediately. But his was not so high that we had to worry about stopping them immediately. But it was definitely not going to be a long-term solution for us to continue to have these topical eye drops, these topical steroids dropped into his eye. So the inflammation went down to 2, and then back up to 4, and then down to 1. We were playing around with the number of eye drops in a day, the dosage, the efficacy. We switched between different types of eye drops, some of them having a greater effect than others. At some points, we did actually see the inflammation went back up to 4+, and this time we started to see spillover into the back of the eye, where some of the cells started to slip back behind the lens. Now we're in to the intermediate range there, and on their way back to the posterior. It's definitely been documented. There are cases where the anterior uveitis becomes posterior uveitis over time. So that was out of the question. We had to really make sure that that did not happen. So the new treatment plan was to treat him systemically rather than locally. So locally would be things like eye drops, taking fluid out, you know. Systemically means now we're either giving a pill or we are injecting something. And the first systemic treatment that we used was methotrexate. Now I had to be trained how to give an injection, and my goodness, nurses are the most wonderful people, aren't they? There's a nurse in the rheumatology clinic at Children's Hospital named Jan who literally allowed me to inject her with saline. I practiced on her, and she pointed to other bruises on her arm where other parents also had been practicing on her. That is dedication to a job. But thank goodness, because I had to start injecting Grayson. I believe I had to give him his first injection that night. So what is methotrexate? It's basically a cancer treatment that has been around since about the 1940s, I believe, and is used. It's basically a drug that diminishes the production of cells that are rapidly dividing. So this is a good treatment for cancer, for example, where cells are rapidly dividing. It also happens to be a treatment that is sometimes effective for things like autoimmune disorders, where you have cells that are rapidly dividing and causing you lots of troubles. So we started injecting the methotrexate, and at some point we went to pills of methotrexate. These, Grayson was slowly, over time, less and less able to tolerate the pills, and so we went back to injections. The efficacy is better. What they call the bioavailability of the bioavailability, I think is the right word, of the drug is better when it's injected directly into the bloodstream rather than being consumed and going through the digestive tract and being filtered out that way. And the methotrexate was, so we were doing methotrexate, and then we were also doing these localized steroid eye drops. And these treatments did, to a certain extent, really help a lot. We were down to a 0, then we came back up to a 2, and then we went down to 0, and then we went back to, by December of 2019, the problem had not resolved. We were still seeing some markers of inflammation. We really were going for absolutely 0. And so starting in December, we decided to work with a product called Humira. It's not really a normal type of, it's not something you can just pick up from your pharmacy. We had to go through quite a lot of trouble. It took us probably an entire 6 weeks to actually get started on Humira. But what Humira is, it's a TNF blocker, and it's very, very, very specific. It eats up, I'm going to put this in my science presentation, but it has a really specific way of eating up the problems of inflammation, and in Grayson's case, it turns out that it was extremely effective. So then it was actually the very, very end of 2019. I believe it was literally December 31st of 2019 when we injected Humira for the first time. And then we continued this and continued Humira, methotrexate, and the steroid eye drops for several months until March 6th. The first checkup after the Humira started, he was clear. His pressure was good. There were no cells, no KPs. There was no flare, which I think is a measure of like the proteins. And so we decided to wean out the eye drops. The eye drops were first to go. And of course, that was about a year ago, a year and a month ago, and he has been clear on every single visit since then. So Humira seemed to be the thing. So to this day, we have 5 injections every month. We have about 3 injections of methotrexate. The methotrexate is needed because it helps to, that the body doesn't react against the Humira. The Humira is twice a month, and the methotrexate is about 3 times a month. And that is what we are doing to this day. Uveitis is a strange beast. It is of different severity in every single patient. It has different causes. It is oftentimes something that is attached to JIA. It also has several other autoimmune conditions it could be attached to as well. Or it could be completely idiopathic, which means that there's no particular cause anywhere. There's no particular, what's the word for it? Concomitant disorders that it's going along with. It could just be something on its own. My own personal thoughts on Grayson's uveitis is this. I think that he that he had uveitis for some time and we didn't know it. It is a completely invisible illness. It has no visible symptoms, especially in Grayson's case, a case like Grayson's, which I think is a little unusual, where he had no pain in his eye at all. Oftentimes people with anterior uveitis will talk about a throbbing behind their eye or some pressure in their eye, stinging pain, light sensitivity, and redness of the eye. And he had none of those things. So I think he actually had asymptomatic uveitis, and asymptomatic interior uveitis for some time, and we just didn't know it. We just didn't know it. And it was the knee problem that brought us to the doctor in the first place, and that got us looking inside of his eye. This is not what our ophthalmologist thinks. Our ophthalmologist thinks that the knee problem and the eye problem both started at the same time, which was around Thanksgiving of 2018, and probably due to some stressors that were happening in his life at that time. That's where these things started to flare up. There is no test, there is no genetic test to test for the presence of JIA. It does seem to be a genetic disorder. He probably was born with this condition. He had it. He gets flare-ups of his knees. It's something we're going to always have to watch. The uveitis is something that we're also always going to have to watch for. Hopefully in his condition he will grow out of it and he will no longer have these kind of issues in the future. I personally think that that's probably true of the knees. I'm not so sure that it's true of the eyes. I'm not sure that you outgrow uveitis, but you know, time will tell. I certainly hope so. I certainly hope so, because it's something that it's a drag. If nothing else, it's a drag to have to keep on these treatments. But of course our eyes are very important. So it's really, really hard to say, because again, the trend is kind of like statistics would tell you. The joint problems come first, the uveitis comes several years later, but there are exceptions to that. There are people who actually had it the other way, where the uveitis was first, the JIA came, or the joint problems came second, or that maybe they did get them, you know, pretty much at the same time. The problem is that a lot of these things are invisible. The problems in the eyes are completely invisible. So who really knows when it started or how it started? It's really difficult to know. It's difficult to know. All right, in my next video, I'm going to be talking about the science behind all of these medications, because I just think it's kind of interesting. So if you want that level of, if you're also interested in medications and how they work, then feel free to tune into my next video. And the one after that, the video after that, I will be interviewing Grayson. I was walking him to school the other day, and he said, I was talking about, like, I'm gonna make a video today about JIA, and he said, okay, when are you going to interview me? So, all right, so that'll be coming up.